invigorated and you want to get to your dinner. But we have one other task this afternoon. We have Phyllis Eaton that's defending her proposal. And we're asking, we don't have to ask you to give her all the questions and suggestions that you can think of at this point. And I will let her introduce herself to you and tell where you work and how you got to study the topic that you have selected.
Welcome, everyone. It's early evening, I guess, already. Hopefully it's a good sign that it's still light outside. First off, my name is Phyllis Eaton, and my topic right now is coping strategies of family members of individuals seeking inpatient psychiatric treatment. Everyone hear me, first off, because we had to do some adjustment with the mic. Who am I? I'm currently full-time faculty over at the School of Nursing at Old Dominion University, which for those who are from out of state, I'm from Chesapeake, Virginia, and I teach over in Norfolk, Virginia, which is right over the water, so it's not too far from here. I also am a clinical nurse specialist, part-time at Centera Behavioral Health Systems, and that's at Norfolk General, which is a level 1 trauma hospital, and that's in Norfolk too. It's right down the street from Old Dominion. I'm currently, my interests are mental health and community health. And how I came up with this topic, for those who are in class with me, will probably already know some of the stuff that I'm going to go over today, because mental health is my passion. I have been working in mental health, for about 20 years since my son was born. But when I started nursing, I started as a med-surg nurse, and I actually hated mental health. And I was really scared as a student, and as life events happened to me, I got interested in psychiatric nursing and ended up now working in that field. I currently work as a clinical nurse specialist at Norfolk General, but in a role of also an emergency crisis nurse. We call it a psychiatric emergency response system. And this is where I found what I view as one of the major problems in the mental health field is funding areas and the lack of treatments and the coordination of care and the family's ability to deal with all of this. And as I go on in my presentation, I'll hopefully make it a little clearer, why I chose this particular topic. Going back to the topic, I'm actually looking at how families cope with individuals seeking inpatient treatment. And the reason why I put down seeking inpatient treatment is twofold. One is because I have the population in terms of subjects available to me, and that's over at Norfolk General. But also I wanted to look at families that were not necessarily associated with individuals in an inpatient setting alone. Okay, because I felt that would limited my study for one thing, but also I was looking at more so the family, how families cope to get to that process of putting somebody to the inpatient. Okay, hopefully I make it a little clearer. If not, please ask me later on. Okay, so that's where I'm from. That's my passion, and hopefully we'll be able to see this. My introduction is about mental illness, and I'm throwing out a little bit of statistics. There's a lot of numbers out there. These are some relevant statistics that I felt are very important for us to know as a health care provider community, that more than 25% of the world's population have some type of mental illness. That's a lot. That's 1 in 4. Okay, and in the United States, we have 26.2. This is a new statistics out of 2007. So 26.2. So actually, we're higher than the world average of having some type of being affected with some type of mental illness. And this is another, I think, important statistic to look at, is that It accounts for mental illness, accounts for more years lived with a disability than any other disease except heart disease. That's any other, that's diabetes, that's kidney, any other than heart disease. Okay. I'm a very visual person in terms of learning. This is one of my favorite pictures. When I look at this, I see hope, I see inspiration, I see sunshine, and if you know who the artist is, it's Van Gogh, and the title is Still Life, 12 cent bottles in a vase. It's hanging in my office, at work. And when I look at this, I see hope. I see that if you know anything about Van Gogh, he was mentally ill. They say that he's now more classified as bipolar than schizophrenic. I went to this conference a couple of years ago. We talked all about mental health issues and used Van Gogh's paintings to interpret different types of disease processes, and they came up with that. They concluded that he was more bipolar. But when I look at this as hope, and that's what I want to achieve in terms of my research and my contribution to life. I tell my kids and my students that, we have to give back something. We're not just here because, to use the land and to use everyone else, that we should be giving back something because, we've been very blessed with other things in our lives. So when I see that, it kind of gives me hope and inspiration, because the following, you'll see, tells you, the disparities in terms of health care for mentally ill versus physically ill. I don't know if, I know a lot of you here are from different states, and mental illness is treated differently according to the different states, and it has a lot to do with funding, which I'm going to get to in a minute. But especially in Virginia, we're like number 48 in terms of the states of providing treatment and monies to mental health treatment. And you'll see across the country, state hospitals, state hospitals are downsizing. Okay, not cost effective, a variety of reasons, lack of funding. Okay, so what happens to these patients? Inpatient psychiatric hospitalizations are on the rise. Okay, but what happens is that they're all going to the inpatient beds, which leaves some people having shorter stays because they're trying to get more people in, and so they're discharging sooner and sooner. Medicaid is a very important piece especially with people who have chronic mental illness, because that's where they receive most of their funding from. And states now are decreasing more and more funding, especially to Medicaid. We'll talk about it a little bit later. Mental health treatment has shifted to local communities, meaning state hospitals are decreasing, inpatients are overloaded, and they're shifting patients outwards, so communities get the brunt of the patients. Problem is, what's happening? Communities are getting overwhelmed. So what does that leave us? Outpatient waiting lists are over 6 weeks long. Some cases I read were up to 3 months. Okay, so that means I'm discharged from the hospital, probably earlier than I would have been a couple years ago. I don't get an appointment until at least 6 weeks. What happens during that time? The use of the shorter stays leading to frequent rehospitalization. No brainer here, I'm thinking, because I'm getting no help within that outpatient continuation of care kind of period, that I decompensate and I go back into the hospital. Okay, focus is now greatly shifted to somebody who can pick up the slack. The only people that are left are family. Who else is going to take care of them? All right. Hopefully they have family. Studies have indicated that families caring for individuals with mental illness suffer from increased levels of stress and caregiver burden. So now we're adding more stress to the family. Problem statement. Mentally ill individuals are at greater risk of having negative treatment outcomes with families who are unable to cope effectively. Okay? So in this piece, this system thing that's going on here is the family piece. And this is the portion of where I'm focusing my dissertation on, is looking at how we can help this particular family. In order to do that, we have to understand some things first. We have to understand that the illness impacts not just the one person, but the whole family. About half, and some books go from, articles I've read, almost up to 65% of the chronically mentally ill live with their family. That's a huge burden for families. The support that they have to give to this particular person is sometimes very overwhelming. The last line here, they experience economic strain, isolation, stigma, and burnout. This is like really, really important. These are some of the factors that families are affected by. The cost of the treatments, the inability sometimes of the patient not to be able to work, the isolation due to the having to care for them and not able to leave them alone, and also associated with the stigma of association in terms of mental illness alone puts them into isolation, either real or perceived, have a stigma. And caring for them and the chronicity of this illness, this mental illness, once you, it's not like I take a pill and I'm better. Yeah, I can take a Prozac, okay, but I have to do other things to keep myself well, and sometimes I decompensate, and I have to have some support. Hopefully I have some support to help me through these particular times. So, the family has become vital in this rehabilitation period. So what I'm going to look at is this, if they're like a vital source in terms of being able to help the patient transition from inpatient to outpatient. They're kind of now placed upon them the burden of this type of rehabilitation. And on top of that, they have their own normal stressors of everyday life that occurs. If 1 out of 4 people have mental illness, chances are maybe someone else in their family has a mental illness. Okay, and this is my little man tearing out their head because what do I do now? How can they cope with this? Many families believe they do not have the necessary tools to help with managing the mental illness and their own emotional needs. So they've already admitted, yeah, we come and help, but research has shown that they say that we don't know what to do. We don't know how to cope with this. Okay, little research has been done on how the specific variables of their own life events and the resources available impact the family's coping ability. And especially when I was doing my lit review, when we were talking earlier in the day regarding from different countries who was doing research. And actually, like Sweden, Norway, Canada, United Kingdom, big research people on inpatient psychiatric treatment. United States, America, we tended, in literature review, tended to focus on different types of coping strategies, such as spirituality, the use of religion, support groups, found lots of that. But the actual data in reference to these specific variables was limited. Significance of the problem. Again, I'm going back to funding. This war is costing us a lot of money, someone said earlier, and one of the things I want you to know is that in the 2008 budget that was proposed, that there's a $77 million cut for the Center of Health, for Center for Mental Health Services, which includes mental health rehabilitation services. And that was one of the things that we said that we actually needed and that we were lacking, because families are now seen as taking the brunt of this gap in service. So what does this all mean? It means it translates to less available treatment options for the mentally ill. If you believe in history, it repeats itself. I just hate to see, there's a slide up here, I don't know if you can read it. This is the tranquilizing chair used in the treatment of the mentally ill in the 19th century. is, are we going to go back to this type of treatment? That's why I look at that picture and I'm of Van Gogh and I'm inspired, and hopefully we won't, get to that point. Significance of the problem. Another thing is that when somebody is diagnosed with mentally ill, about half, the statistics say, of the mentally ill have more than one problem, which adds to even mental health diagnosis. So that leads to even more problems with caring and being able to manage their disease process. And if families believe that they don't have the coping strategies and the resources available to help these people, there's this big gap in service. Understanding what affects the family's ability to cope is vital for health care providers. If I can help this family that's going to receive this patient back into their home or provide support to them, then I have improved the outcomes of that patient. Identifying coping strategies in families living with mental illness will help to improve patient outcomes and support the family's ability to cope with the situation. That's what I'm hoping. So, purposes. I have 4, hopefully. One is to investigate the coping strategies. It's of family members of individuals seeking inpatient psychiatric treatment. Okay, so I'm looking at their coping strategies. We talked about earlier seeing what they particularly use in terms of for coping. Is it, I'm going to get into it in a second, support groups, spirituality, are they emotionally focused or problem-focused strategies? I'm also going to examine the relationship between family resources, life events, and depression in regards to coping, family coping. And we're going to be looking at demographic factors such as age, gender, ethnicity, and income level. My third one is to increase the understanding of how families cope with mental illness in an effort to help them identify their present level of coping and aid in providing new positive coping strategies as needed. I'm hoping that I can extend this after this research to make this more of an intervention study and do an intervention once I found out that what they're lacking, that maybe we can provide, especially working in an inpatient basis, or to prepare them for their loved one coming home. And my last one is to add to the body of nursing knowledge regarding the family's use of support systems, depression among family members, and the effective pileup of life events on the family's ability to cope with mental illness. So in a second I'll go over actually what I'm going to be looking at. Review of literature. As you know, or maybe you don't know, but you have to write a bunch of stuff about a concept. And my concept is coping. And there's a lot out there, okay? And you have to focus on what particular, maybe, avenue of the concept you would like to go with in terms of your study. Has different meanings, managing taxing circumstances to transactional process, which changes over time, and within its situational context. This is actually Lazarus and Volkman. And they view coping as a process, and I really like their idea or their concept of coping because it looks at it as a perception of the way one thinks and does when encountering stress. And then the individual then reacts, or the behavior as the encounter unfolds. In the next few slides, I've thrown in like 3 pertinent studies that from my lit review, just to give you a little bit of a sampling regarding the direction I wanted to go in. And I actually looked at this one by Osman and Hansen, and it was about coping strategies of relatives or families of admitted psychiatric patients, so it's relevant to my particular study. They actually looked at burden of caregiver with it also. In this particular study, it was a quantitative study which they looked at with the tool that they designed. It's actually a mixed method, I should say. They designed a tool and they used it in terms of coping strategies that families use. And they did a qualitative piece by short answer questions. And they found that a family has to learn how to cope with the patient's behavior and limited financial resources. They coordinate services with the medical and mental health community. They're tasked with not only dealing with all of the outside types of activities, but their own reactions to this particular loved one having a disease. I put this in there because they also focused on problem solving versus emotional focused coping strategy, which is a Lazarus and Bookman type of concept. And problem solving strategies were used when situations were favorable to change, which coincided with Lazarus and Bookman, and also they used emotional strategies when it was chronic or unable to change. Another study by Enns, Redden, and McDonald examined family members of people admitted to a psychiatric facility, and they looked at it at the aspect that I was looking at it as seeing them as a resource for rehabilitation, which kind of fit right into the direction I was going. So I, liked this study. It was a 99 study, but it seemed to fit what I was going, the direction I was going in. They also used similar instruments. They used the Family Inventory of Resource for Management of the Firm and the Family Crisis-Oriented Personnel and Evaluation Scales, FCOPS, and thereby McCubbin. Okay. So what did they find? Families reported less confidence in themselves. Participants were less likely to utilize their extended family. Males were less likely than females to seek spiritual support. So they were looking at, how they coped and what types of coping strategies they used. They also said that they concluded that they felt that families could be considered as a vital part of the rehabilitation process if they were provided information regarding how to cope with their loved one. So that kind of fit right into the direction I was going into. Another study, Perkins, Wynn, Murray, Murphy, and Schmidt, examined how families coped with a mentally ill family member. And this one I put in there was a qualitative study that I liked. It addressed bulimia patients, but they also focused on the positive aspects of caring for them, and what were some of the positive coping strategies that were out there. So kind of fed some of my interest in terms of this is something that maybe we could focus on and asking families, do they spend time away from their role? Are they being optimistic? Are they stepping back and allowing time for themselves and having their loved one take some control of their life? I went on and I just did some summary of the pertinent literature, because you could go on, and those who did a lit review, that you can just keep on throwing studies out there. So I kind of summarized them in a one-liner to give you some direction that I wanted to go into. The level of support is directly related to the health and well-being of the family. So I'm looking at that. I'm looking to see if their support systems, if they're in their ability to cope with their loved one, are they utilizing appropriate support systems, and if so, is it affecting their quality of life in terms of health and well-being? Research indicates that spirituality contributes to mental health, and it's related to psychological functioning differently depending upon the religion and culture. This is a big piece, and actually we had a lot of research done, like I said, on spirituality and culture and in reference to mental illness. Cultural impacts, the appraisal of burden and the relative negative attitudes in this particular study and behavior. The study that I cited next is a study by Donnelly in 2005, examined the mental health beliefs of Korean American parents of adult mentally ill children. And I actually wrote my chapters earlier in the year, and this is a study that I really liked in terms of how, even though they were educated in the United States and that they worked in the United States, they went back and used their first line was their traditional Chinese medicine. And then when that failed, they used Western medicine. And it just so happened this whole thing with Virginia Tech occurring. And my sons go to Virginia Tech, and my one son was in the building next to the shooting. And why did they pick that building versus my son's building? I think God only knows. But when I reread this article, I looked at it and it said stuff like the family's view in the Korean American population, that the family's view that mental illness is a family illness and a family problems, and actually it's a stigma or disgrace to be mentally ill, and that they try to resolve the problem within the family, and then they seek out maybe religious people in their community to help rid, their loved one of this, demon or. So, and it's after that, then they seek that Western medicine. And if you've read anything about Virginia Tech and what the family had been trying to do, and that whole religious piece, and I'm going, this just matches my article, and, we were talking earlier about, making mental health, because of the incident, more aware in terms of, people in the community, more aware of how mental illness can occur. But some of my peers and I, we're kind of leery about the double-edged sword in terms of, is this going to make, this awareness going to make it more stricter in terms of treatment? Where is our, I'm just kind of wondering about our personal rights, but that's a side note. Okay, I have a passion towards that, so I'll have to keep that there. But it's important to know, especially for this study, that I examined the culture piece and the use of spirituality in it. And that's why my literature review reflects that. The last one is the stressors from the previous year. Okay, rather than the actual stressor, they predict negative family functioning. So instead of just looking at the crisis of them going to the hospital, okay, that caused them an inability to cope with the situation. In this particular article, it was like the actual event that brought them to seek care was just like the last straw type of thing. It was the events of the whole year that actually led up to this. And that's one of the things I'm going to be looking at is life events. Another aspect I'm going to be looking at is the family coping and their emotional reactions can adversely affect the health of the family. Families caring for mentally ill family members have an increased risk of what? Developing their own mental health problems. So I'm going to be looking at depression. A little man here depressed. Hopefully he'll see the bright sun pretty soon. Okay? So, my system, my conceptual framework. I believe it's a system problem. And I feel that Newman Systems model works well with my particular research. For those who don't know Newman's model, she views client system as a dynamic, the interrelating variables that interact continuously with stressors from the environment, which sounds about right with our mentally ill population. All client systems have 5 interrelated variables which work simultaneously as the client responds to the internal and external environment. And this is the basis for my particular model here. And as you can see, that Newman Systems is my model. My theory is theory of coping strategies among families, members of individuals seeking inpatient psychiatric treatment. It's a of. I had to change it because it's supposed to be up because I spoke with Dr. Fawcett yesterday, and she critiqued a little bit here, and I have to follow up with her, and I apologize because I thought I went through all my slides and corrected, but I just corrected this last night because I'm not looking among family members, I'm looking at families. So that's why you do this trial run here, and we have people hopefully think of that. But I changed it as of last night. But the conceptual model concepts I'm looking at are the physiological, psychological, social, cultural, developmental, and spiritual. And what I'm using is the middle range theories. Parts are the with the physiological is the health and well-being of the family. And my research method that I'm going to be utilizing is the FIRM, which has a subscale which looks at the family well-being and health. In the middle range theory, for the psychological piece, I'm looking at depression level, and that's going to be, I'm going to be utilizing the Beck depression scale. It's revised, it's the second edition type of thing. And social culture is the social cultural supports, which is also known from FCOPS and interview questions, and also through Burrow. And developmental, I'm going to look at the family stage and life events, because I think that's very important in terms of how they cope with a particular situation. And I'm going to be using the file with that. It's also it's a family inventory of life events. It's also by McGee. And the spirituality piece, I'm going to look at spirituality as a coping strategy, and I will be using the FCOPS for that too, because it has a subscale for it too. Okay. Research questions. I have like 11. And I apologize for the time. It's already 5:30. I know. I tried to cut down on my slides here, but it's okay. I'll go over them quickly because they should say what I've already said, so hopefully you'll understand. What coping strategies are used by family members of individuals seeking inpatient psychiatric treatment? What are the common support systems? I'm looking at support systems, coping strategies, the main focus, okay? How they cope, independent support systems. I'm going to use the use of spirituality as a source of, what is the use of spirituality as a source of support for these family members? What is the self-reported measure of the level of depression among these family members? Is there a relationship between family coping and depression among these family members? Is there a relationship between level of family resources and the level of accumulation of stressors, whether we call them pile up or life events, among these family members? What is the relationship between coping strategies and health among these family members? And is there a relationship between the level of family resources and family coping? Is there a relationship between the level of accumulation of stressors and family coping? And then I'm looking at the relationship between the family, between the ethnicity, age, gender, income, and coping to see if there's any relationship there. And does this relationship between coping and levels of family resources differ? And then I'm going to do the demographics of ethnicity, age, gender, and income. Explanatory correlational research design is going to examine the relationship between coping strategies and, here they are, family resources, accumulation of stressors or life events, severity of depression, and age, gender, ethnicity, and income. Okay, so that's my focus. Using a mixed method design, where there's a piece of quantitative and qualitative, and as of Dr. Fawcett's lecture yesterday, mine's going to be mainly quantitative with a few questions. The short answer, there's going to be 3 of them that are going to help hopefully clarify the quantitative data. That's why they're building, they're helping each other. Sample, convenience, sample. I work at the hospital, and I'm going to talk about that in a second for the actual setting, but it's going to be the participants that, for this particular study, are going to be the people that come and seek us out, and that's just convenient for us too. Okay, inclusion criteria, they're going to be adults, 18 years of age or older, and they're going to be family members seeking inpatient mental health treatment, and I'm going to specify that they are family members that, and this will be on my demographic sheet, that if they live with the patient, okay, or they are in order to receive or provide substantial support to the patient. And Reason being is that I just don't want a family member who just flew in from, California, who he's never really seen or provided any support, to be filling out my data. And I probably, what I'm going to be doing is not asking them at the time, but when my demographic sheet, if it's just an occasional visit, then they will be excluded from the study. Family member is anyone who deems the mentally ill individual, that anyone who the mentally ill individual deems as a family, and any ethnicity, gender, and socioeconomic level. In working where I do have the luxury to this population. And when the patients do come to the unit and to the emergency department, they're only allowed to have 2 visitors. I mean, there's only 2 people that can be with them. So there is not a large 100 people in their family. So that will help me a lot in terms of my exclusion criteria. And through working in there for a number of years as a first clinician, the people who bring them to the hospital are usually the ones that provide them the most support. So I'm hopeful in getting a sample large enough. I'm looking at 186, but that's discussed later on. The setting will be in Hampton Roads area of Virginia, and I'm specifically going to be looking at the Norfolk and Virginia Beach areas. For those who are not familiar with Centera has a lot of hospitals in this area. And as a clinician, I go to different hospitals in the emergency department areas. And I'm going to be going to the Norfolk General Hospital, Lee Hospital, that's in also Norfolk, Bayside's in Virginia Beach, and Princess Anne Health Campus, which is a preliminary to a hospital, is in Virginia Beach. So I have access to it. Population, how many do they see, and how can I, the numbers are on an average, the first clinicians see 255 people in the emergency departments. Out of those, I've been tracking approximately about 70% of them come with family members. So I'm hoping that it will be a good population. Inpatients will be also, we run for admissions about 80 to 85 patients a month. So I think I'll be able to get a good sample size there. I have, what I'm going to do after this, if everything gets approved, is go through my RBs first at Hampton and then at Centera. I've already spoken with the nurse executor for Centera and the operating center manager for behavioral health systems. Lois Kirchner is promising me an expedited type of IRB because she's moving towards that magnet status and she's really looking. I know, but I'm open to. I like the population in terms of the conveniency and the numbers, and so I'm working with them, and hopefully they'll work with me in regards to that. If not, I'll just alter my plan. In the process here, the first clinician will meet with the particular patient and family, and then they will ask if they would like to participate in this particular study. Either myself or one other researcher who is also a first clinician will be my research assistant in this. Participants will provide the information in describing the study. They will have an information sheet, and they will be the name, the purpose, possible risks and benefits, and the possible effects of the study to the fields of mental health and nursing. Informed consents will be obtained. This is really important for the psychiatric piece because that confidentiality is very vital in the mental health system itself. There's strict requirements from the state, from human rights, and so that will be reiterated throughout the process, and a copy will give each patient. I am going to be the researcher. I have expertise in that field. I have, like I said, a number of years of working over there and also working in that particular discipline as a crisis clinician. And I have one research assistant who's willing to work with me. And then only a selected family members will be asked to participate in the semi-structured interview in addition to the surveys, and this will be conducted by myself. I do have the therapy expertise and do that as an outpatient. Okay? And at that time we'll be re-informed about the confidentiality and of course with the ability to put the study at any time. These are my instruments. I know we're running short on time, but I'm going to go over them anyway. F-COPE is a 30-item instrument, measures family coping, identifies problem solving and behavioral strategies of families in crisis. The file, or the family inventory of life events, is a 71-item instrument. Notes changes, normative and non-normative, normal and non-normal, changes in life changes and life events. It identifies families who have an accumulation of stressors. They also, in the file, also can categorize it in terms of age groups. The firm is a 69-item, identifies perceived family resources, examines the presence of personal and family system, and social support resources. Also looks at family well-being and health. And last but not least is the back depression inventory. They're all self-rating. I chose back because it is a self-rating also, and there's the perceived level of depression that addresses behavioral manifestations of depression. Demographic information, demographics, semi-structured interview, consists of 3 open-ended questions. I actually redid this a little bit because talking with Dr. Fawcett, she recommended that less is more, and that to do more open-ended is like, instead of being very specific in terms of, I would say, what is your use of spirituality? And she said, what do you want to know? Let them talk and say coping strategies. So that's what I changed to. Also, I went to what are your family stressors? And last, the role of a healthcare professional in this. So it was helpful for me yesterday to have her, so I was able to critique this beforehand. Demographic data is summarized by descriptive statistics. Pearson's product moment correlations coefficient will be used to examine the relationship between coping and the variables. Also, I will be doing a frequency distribution to analyze the F-COPE file firm and the VEC. Again, the Pearson's product of moment correlations coefficient will be performed to assess the correlation between family resources and the level of accumulation of stressors, severity of depression and coping, and multiple regression will be used to determine what variable, family resource, accumulation of stressors, and the level of pressure is the best predictor of a successful coping. 3 short answer questions will be recorded in these, and the responses will be noted. Since qualitative and quantitative data will be collected, almost finished. Methods of triangulation will be used in the analysis of data. So this provides a more holistic picture with the complementary methods. Hopefully we'll add another layer of data that will aid in the validity of the conclusion. Any questions? I'm finding myself because I'm like done.
We will take comments from you all that heard, and if you want to give her some suggestions, at this point, that's what she will take notes on. The committee has listened and has looked at this, and there are a lot of things that we're not going to go over with the group that we need to talk about. But we're asking you to give her suggestions of what you see, and if you could give her little short snippets of what you see that would help her to complete the study in a timely manner.
Well, seeing that this is a mental health project, I looked at all of your scales that instruments you're going to use. Are you going to give them all to them at one time?
It's not, that's a good question. In fact, it's not for the mentally ill.
It's the family.
It's the family. And
Okay.
actually, I was going to bring this up in my discussion because I don't know if you're aware of this, but when you're waiting in the emergency department for any feedback regarding after you're seen, you know what the average time is? 6 hours for mental health at Norfolk General. So they're sitting there for 6 hours, the family. I'm hoping I keep this as a convenient kind of captive audience, that they give them something to do.
But don't you think that's going to make them more stressful, waiting for them to sit there? I think about myself if I was in the emergency room. Wouldn't you think that's going to heighten? Would that give you adequate information for your families if they're under stress already with their family member in the emergency room?
Well, basically, I want that. I wanted to, this is the population that I was looking at, is these are the people that are going to take these patients home. And they're having this particular crisis or situation in their life. I want to know, how can we help them?
Okay.
I don't want to look at them when they're at home and everything is fine and they say life is coping, is good. You know, that's my objective, if that makes any sense.
I don't want to answer that question. I don't want to answer any questionnaires. My family members.
Then you don't have to, but you know, in my experience working with them, they want to talk to you. They want to sit down, and if I could spend an hour with them, they would love it. You know, and then the time. How long does it take to do all the testing and the overload? That's something that I've thought about, and I've discussed that with my committee. But, you know, again, they're sitting there. The timing says about 45 minutes. I had done it similar, and it took me 20 minutes, but then again, I was in a different situation. So, you know, that's what I'm hoping. That's the kind of patients, people I want to capture. Thank you for your question.
Hey, Phyllis, first I want to commend you on your defense of your proposal. It was an excellent job that you did.
So,
but I do have some suggestions, and that's to follow up on the first commenter on the burden for mental ill patients or families with mental illness in them. You have to consider that. And if you were to write a grant on the same proposal, that would be something that they would really highly mark you down on, because the scales are so comprehensive, and it's about 200 questions. I kind of
it's
quickly...
It's 187, I think, or something.
Yeah,
190.
it's a lot of questions
Yeah.
for someone, a family that's in crisis, because as you know, I'm a mental health nurse too, and they're in crisis, and so you're asking them to answer a lot of questions in a time in which they're having crisis. And I do know that it's therapeutic for them to talk. However, you have to consider the burden for the protection of their sanity and their human subject, even though they're not the one experiencing the mental illness, their family members are, and that causes them distress. So
I think you that was one of my areas that I had a little concerned about, but I was waiting. Is it the burden going to be, you know, and maybe because I was working in that particular field area, that I thought that they'd be able to handle it. So it's great to have an outside view to say that maybe this is just a little too zealous in terms of what you're trying to accomplish. So thank you. Yes.
I just want to commend you on your enthusiasm for and passion. We already see that. We feel it.
Feel it?
However,
Okay.
I think we're going to have to taper it if this is, you know, if we want you to get through this.
Okay.
And at some point, I'm sure your committee is going to share that with you. But I share a similar concern about respondent fatigue.
Respondent fatigue.
And when I look at all of the variables that you want to measure, I just ask that you step back for a little while and taper that to something that this is a process. And there is life after the process.
Okay.
That you can continue, okay?
Actually, this is a streamline from what I was doing before. We get there.
This is an excellent study, but the reason I just wanted to make a comment. I used to do psychiatric nursing as well, and when you had mentioned in the sample and study, family members, anyone who's a mentally ill individual deems to be family, a lot of times when we ask that question, who do you feel is your family, it's another mentally ill patient that they're bringing in. I mean, so I don't know, are you going to specify when you say family, Because I see you got that kind of broad, it's whoever they deem to be their family.
Good question. Actually, when you're, okay, there's a lot of mentally ill people out there that you don't even know they're mentally ill.
Well, that's true.
So, for me to exclude people who are mentally ill, these are the people that they're going home to, okay? These are the people that are going home to. So I want to make, the population I'm looking at are the people that are going to care for them. And if they're mentally ill also, okay, which I did note in my lit review, that, you have a high incidence in terms of depression. I want to make sure I capture that population, because those are the people that I'm hopefully one day, in my overzealousness here, help and treat. But you're correct with that.
So maybe specifically say, I guess, who are you going home, who are you caring for, your caregiver, something like that.
It's not a caregiver study. It's not a caregiver study. Okay, I want to differentiate between that, because you don't necessarily have to provide the support if I'm caring for that person. I might not be living with that person. Okay, but I deal with this person every day. How am I, the family, not the patient? How am I, as the family member, going to be able to manage and to live with this person that's mentally ill? What are my coping strategies that I have available?
Okay, well, you clarified that for me. Not looking at that, I was thinking.
I enjoyed it, and it was informative. I have a question, however. How are you going to make sure that your sample are people actually seeking inpatient treatment? Because when you see a client in the emergency room, they're presenting for problems, and their level of care hasn't been determined. So will someone screen for you and then forward those just seeking inpatient treatment to you? Or are you going to broaden this? Because when you go to the emergency room, your level of care is dictated, of course, by the symptomatology that you present. And that may not always need inpatient intervention.
Great question. In fact, I was expecting that question. When I wrote down seeking, it doesn't necessarily mean, and go back to the original title, is seeking inpatient psychiatric treatment. When a patient comes to the emergency department, they're seeking help. They're seeking some type of treatment, and it's an intervention. And it. How can I say this without getting too confused? This leads to them into the inpatient setting. So, I mean, they might necessarily want to have treatment, treat me and then let me go, okay? There is a possibility of that, but it's the family members that I'm looking at. So one of the things I was thinking about is having when the first clinician do their initial assessment, remember that was the first thing, and that they would assess and see if they would be appropriate for the study and if they were seeking the inpatient care. So I'm hoping, and through working in there, that approximately 90%, if not more, of the people that come to our emergency department and in other studies, they are seeking some type of treatment, inpatient treatment. That's why they're going to get help. There's a percentage who go there because they don't have a counselor or they need a medication refill. Those are the people, and I should say that in my exclusionary criteria, that would not be counted. Does that clarify it a little bit? So the prisoners would make that initial speaking with them, make that assessment, and then offer them participation in the study. So that would be
Screen and triage only those that are seeking inpatient care to you.
well, actually, they actually will have one of the clinicians that will be working with me. Will be doing. She works full time. Okay, and then when I'm working too. Yeah, that's why I have somebody. They have all these different. She works full time, so she's willing to help me do that. So, hoping to get that.
I just wanted to commend you. I think you did a very good job. And it's very informative, and I think I've learned quite a bit today from it. One of my questions is that I have a psych background too, having been taught, teaching it and practicing it as well. What sequential steps will you take? What would be the sequential steps that you would take
to maintain confidentiality since it is a big problem with the mental health population?
That's a great question, and I brought that up several times with that. Confidentiality, they will receive information regarding the study. They also will receive in that particular confidentiality statement saying that the information will be kept, the demographic sheet will be kept separate from the data, and they would have be kept in different places. Also, that I would store it in a lock safe for 5 years. So, to say it's not going to go any further, that's what I'm hopefully going to keep on reiterating numerous times. And saying that I separate the data, the demographic sheet from the data, and keep it in 2 different places. That way, the access wouldn't be there. But I would have encrypted types of things so I can know which one replied to the particular data. Yeah, the codes, but separating that, and then reiterating again every time that we interface. But it's difficult in a regular psych setting how to keep that hospitalization, private. And in our interview, we actually have a psych in the hospitals. There's actually a psych room, where we can do a consultation, so they'll be able to go to the consultation room, and I can do the interview there. Okay, so that will be separate from that. Okay, I'm sorry, I talked too much. Hey.
One question. I heard you mention a sample size. Did you do a power analysis to come to that sample size,
actually,
or are you basing it on
the
number
number
of
power.
patients you see to you?
Okay, that's a great question, and I was hoping that it would kind of sneak right by. And this was addressed earlier. I have a statistician consultant who's working with me regarding this, but he's currently working with another person who is going to defend tomorrow. So I'm not one of the priority people, but when we initially talked, we did the power analysis, 80%, a moderate effect. He looked at that. But I'm going to, after this interaction and getting some feedback regarding downsizing scales, I might have a different number for you. But that's where I'm at with that. Okay, thank you.
Phyllis, I had a question about your qualitative approach.
Okay.
And how you're going to, what is your sample size for that going to be? Or do you have a generalized sample size that you think you might be targeting? And then for your semi-structured interview, you're saying that you're going to look at role of the healthcare professional. Where does that correspond with your questions that you're asking?
Okay, there'll be the 3 questions. Actually, I had more questions, and as of yesterday, I switched them because Dr. Fawcett, I was very specific in regarding the role of the healthcare provider, and actually I asked, what can the healthcare provider give you or help you with in managing aftercare? And she said that was too narrow, and that I needed to just focus on, what can the healthcare professionals do in terms of helping you cope.
If you're asking a question about healthcare professionals in your semi-structured interview guide, I would think that you would have something in your research question toward that end.
Okay, that's a very good point. I'm writing this down right now.
We have one last question, Iris.
Yes, Phyllis. My question is more for clarification on my own part. Your sample, you're looking at family members.
I'm just listening, sorry. I'm writing this down so I don't forget it, what you said.
But I thought I heard you say afterward, while answering another question, that this is not a caregiver study.
It's not, the title of it is not caregivers.
But the family members are caring for someone with mental illness. That's one part of my question. The other part of my question is, in your collection of samples, do you look or address how long the patient has been diagnosed with mental illness and how long they've been dealing with this process of coping? Is this a family member who's in and out of their lives? Are they recently dealing with this? Are there children of this patient?
Okay.
And those factors.
Those are the same questions I had, and I was focusing on earlier, but it became overwhelming in terms of that. Getting back to The original question, I'm sorry, I missed it in terms of what was it?
Are you excluding people based upon their length of illness or how many?
No, I don't have an exclusion for that. And I guess I actually did mention earlier that I'm looking at somebody on the demographic sheet will ask, do you live with this person or do you provide, or do you provide support? And I can't remember, I don't have it with me right now, if it's, moderate or substantial type of, I can't remember how I worded it, support. And based on that, if they say that, they provide occasional support, it's a check thing. If they provide occasional support, they would be excluded.
And length of time provided support, length of years provided.
No, I didn't, there's a lot of data that looks at, how long someone's taking care of somebody and that influences their ways of coping, with their particular loved one. But my study's not going to be looking at it. I was initially looking at that, but
I just want to make a comment. I appreciate your work, first of all, and secondly, you may want to consider adding crisis to your title, because at this point your study is only going to deal with family members in crisis, and that may skew your information, your data.
good point. We were talking about doing a crisis study before that, but see, my study was more of a coping study. So this is where it's working, where it's a working title. It was initially, we talked about doing crisis, but I wanted to focus on the coping strategies. And I guess I could rephrase that and say families in crisis might be something, but then I have to go and explain everything about crisis. And that's just way overwhelming right now. I mean, you know. Okay, I'm sorry. Thank you.
One last comment. I really appreciate the study. When we're talking about psychiatric treatment, are you looking at specific psychiatric diagnoses or just any psychiatric diagnosis?
Any psychiatric, that's a good point to put in there. Any type of psychiatric, if I'm wanting psychiatric, any type of treatment, if I wanted counseling, if I wanted whatever it might be, okay, ECT, etc. I didn't want to exclude anybody in that, so I'm just thinking if they're seeking treatment.
Some of the diagnoses would seem to have more of an impact. Like, for example, a psychotic diagnosis might have more of an impact on coping skills than
Right, and you're correct. There's literature out there that supports that, but you have to go back to what I wanted to study and why I'm studying. I wanted to provide them, find out, investigate their coping strategies so they can be utilized as a rehabilitation. What?
Start. So when your parents stop,
Thank you. You say it.
Okay, that's closure. That's closure.
These are, I gotta go through all my references. Wait. That's a good thing.
she wants you to see her.
I want to see my slide at the end.
She wants you to see her.
Yes, you have to see. See, that's how I felt in this process. But this is how we're going to be in the next process. And my second favorite picture that gives us.
There's a method to it. Thank you.
But as the chair and as co-director of the doctoral program emphasis, I will let you know that when Dr. Hammond speaks to you tomorrow, the question she's going to ask you about your topic, no one asked her what coping was. No one asked her about, she talked about burden, she talked about resources, she talked about cultural and spirituality, she talked about, that should have been the first thing. The first question should have been all of those variables that she mentioned as she was presenting her information. She talked about accumulation And I don't know even if you all know what she meant by accumulation. Using the file and the firm and McCovern's word, he talks about pile up. You all let her say pile up. Nobody asked that question. And these are the kind of questions when you're sitting in the audience, you're listening and research being presented. You need to know you cannot throw out all of these awareness, family functioning, life events, appraisal, locus of control. You can't sit there and listen to all this information and not have a question. And I'm saying not have a comment. Okay, that's mine.
Just one comment from me, and this is not particularly directed at you or the study. No, I'm just saying for me, it's about when we talk about where data will be collected, you really have to guarantee that your site will not be public, because it can be very damaging if results are unfavorable, and so on and so forth. So you just have to talk about a major medical center in the southeastern region, 500-bed hospital, and but you can't say Happy Day nursing home or cul-de-sac hospital or contingency college. You cannot say that. It has to be very general, because the institutions are also opening up resources and so forth. And yes, they should get the results. If there's serious problems, they definitely should get the results. But we can't stand up and say we're going to get the data here, there, some other there. That should not appear in your dissertation, and you shouldn't identify. Eastern, not Mid-Atlantic.
It's my turn. It's my turn. We're going to eat. You guys have been so patient, but I'm so glad that we were able to get our 2 presenters in this afternoon for you to get a good idea of what the process is like